Welcome everyone. This is Dr. Jaitly on your favorite website, MuniMeterHealth.com, which is dedicated to educating you about the human heart and increase the human heart awareness to all. Primarily, it's dedicated to educational channels on two social media, as you know, and we are focusing mainly on medical fraternity to educate them, specifically the interns, the residents, the fellows, and the medical students who are about to take their exams, etc., or preparing for their day-to-day rounds. And likewise also for my colleagues and internists, etc., who are all interested in knowing about the various subjects we discuss on the videos. The general masses, of course, it's primarily for patient education to improve the general awareness about the human heart. But just a note here, if you are experiencing an emergency, please see a doctor right away. Do not watch the video. Obviously, you need to immediately consult your physician, go to the nearest hospital, or call 911, and immediately the ambulance will bring you to the hospital. Without any further ado, I'd like to delve into the subject matter. The matter of the subject today is, what are the effects of hypothyroidism? Remember, it's hypothyroidism on the cardiovascular system. Now, we know that from the previous videos, like we discussed earlier, the hyperthyroidism normally presents with a very hypodynamic state. So this is a hypodynamic state. Here the heart is extremely quiet, if you will. The apex beat is not even felt, whereas in hyperthyroidism there's a hyperdynamic the apical impulse. So it's a hypodynamic apical impulse, if you will. That's one. The blood pressure tends to be with a narrow. So there is a narrow pulse pressure, and the diastolic pressure is high, and that's why there's a narrower pulse pressure noticed here. The systemic vascular resistance here is actually high as opposed to low in hyperthyroidism, and that's why this correlates well with the diastolic blood pressure being high. We have a cardiac output which is low. We have weight gain obviously in these patients, but that's not volume retention, but it's mostly myxedematous tissues, or in general, because these patients have low BMR, or they're hypothermic as well. So these patients tend not to spend so much energy, and there's a weight gain involved. Other than these hemodynamic factors, one also sees obviously the heart rate is going to be slower, and the blood pressure, as I said, there is some diastolic type of hypertension seen, and because of the narrow pulse pressure. Now, there's a fluid retention mostly in the pericardial sacs, or there might be some peritoneal cavity ascites as well, but in general, it's because of the decreased lymphatic clearance in the heart. And therefore, if you were to look at my favorite schematic, here it comes, and when you draw the heart here like that, obviously the pericardium is actually sitting somewhere, if you will, here. So when the pericardium is sitting somewhere outside, there is some fluid which is normally present around the heart, and that's the normal pericardial fluid, about 25 cc's, mainly for keeping the surfaces frictionless. Or just a lubrication that's required just automatically, like we have it for the joints. We have synovial fluids in the joints, therefore we have pericardial fluids also within the pericardial sacs between the parietal and the visceral layer. Now this fluid tends to again, normally there's a flow lymphatic clearance, but the lymphatic clearance is decreased here. So just remember that. So the lymphatic clearance, again, because of the metabolic system being slow, the lymphatic clearance is down, and then there is an increased albumin distribution here, and that leads to obviously increased pericardial. One of the biggest pericardial effusions have been defined are in hypothyroidism. So the fluid tends to accumulate, if you will, throughout these sacs. So in fact, you'll see on the chest x-ray, it appears like there is a huge cardiomegaly. Okay, so sorry if I superimpose the chest X-ray right on where I wrote, but you get the point that there's a huge cardiomegaly here within the chest X-ray, and that should give you a clue right away that there is a pericardial effusion as well. And of course, you can confirm that by an echo where you see that. Now, pericardial effusion is different than the than the cardiac tamponade, because this takes months, years, sometimes to accumulate to that level, and the fluid can be in liters, by the way, just so that you know. But you may not have the intrapericardial pressure higher than the intracardiac chamber pressures, and therefore tamponade is not ensuing yet. But all it takes is extra few fluids, few cc's of fluid to accumulate quickly, and so it's the rate of change of accumulation that determines the cardiac tamponade. But and that of course I have discussed on a different video. But just so that you know, these are your major features. So pericardial effusion will be present, and as I said, so there will be a cardiomegaly also. Now, having defined some of the features and the hemodynamics, let's understand what will you do if. Now, there is one biochemical change that's commonly present is high cholesterol. The total cholesterol, because of the biliary excretion also being reduced, so the total cholesterol rises, and so does the LDL. So they both rise. And now that's one of the features that commonly seen. And then people develop atherosclerosis rather earlier in these patients. And so that's one of the things that's commonly seen, mainly in the aorta. So aortic atherosclerosis has been seen, and of course coronary artery disease also ensues. Now, if you were to do an EKG in these patients, these ECGs will show bradycardia, so there will be sinus bradycardia as opposed to sinus tachycardia, SVT, and atrial fibrillation we see in hyperthyroidism. So here the heart rate is rather slow, and there's low voltage, because there's hardly any voltage. That's one, because of the pericardial effusion, and two, the voltage is low. It's not a hyperdynamic action potentials in individual myocardial cells that one sees. So there is a low voltage, and the heart rate is also low. And the QT prolongation can occur, and that may lead to a torsade type of scenario. By the way, the torsade, and there have been clinical reports where torsades have patients who are constantly having syncope and torsade. Now, once they got their replacements of thyroid, l-thyroxine, the QT disappeared, and the QT rather shortened, and the torsade disappeared. Okay, echo will of course define the pericardial effusion. So one sees a pericardial effusion. The EF is usually normal, chamber size are normal, and but obviously it's a hypodynamic heart with a very slow heart rate, and the heart rate is obviously slow. Sorry, there's a little flicker on my screen here for some reason. Okay, we're fixing those little technical glitches. Now, if you were to do a stress test in these patients, so if you do a stress MPI, for instance, a stress MPI will define that there could be 25% of these patients will have consistent with ischemia. So they'll have ischemia present, but not all of them, they have CAD established. Now, a lot of this ischemia is related to, again, myocardial ability not to be able to efficiently utilize the oxygen during the times of stress, like person is walking or doing a pharmacological stress. So the whole point is that the coronary artery disease is not necessarily present in all 25% of these patients. That's the point I'm making. However, they do have reversal as soon as you reverse the hypothyroidism with T4 or l-thyroxine. As soon as you give l-thyroxine over a period of time, you'll see that if you were to repeat this stress test, that's totally normal. So that has been also shown. Pericardial effusions, of course, you can tap them and reduce the size and immediately relieve them from if they were becoming short of breath, or if sometimes there is some discomfort or pain or just a feeling of fullness within the chest and the heaviness, obviously. So that's hugely relieved. The treatment plan is really based on whether or not, because many of these patients can have associated coronary artery disease. So if they have established coronary artery disease and it's like unstable angina, these patients can be CAS, and they can either go for a PCI, but if they're not a candidate for PCI, they can go for CABG. Okay, but you start the T4 after the operation. So this is after in post-op phase. T4, or when you start the L-thyroxine therapy, always start in the post-op period, and very safely you can start with a full dose of 100 micrograms mcg. I'll write it down here. So this is one. But if you have a stable angina, for instance, and that's the second group, the stable angina patients, normally you start with only about 25 mcg or maybe even 12.5. So start with 12.5 mcg, micrograms. And patients whom you suspect that there might be a CAD present, you can start about 25 there and then gradually increase it to 50 over about 6 to 8 weeks. Remember, it takes about 6 to 8 weeks to really do all of this. So it's not an easy, quick titration. Remember that. It's a slow titration. So that's where we are. So in a nutshell, you've learned hypothyroidism presenting with a very, very hypodynamic apical impulse. Heart rate is slow, very slow, like 40 or 50. Blood pressures in general, our diastolic blood pressures are high, and the narrow pulse pressure, cardiac output is low, about 3 to 4 liters only. And total cholesterol and LDL are high because of the slower excretion to the biliary system, and as a result, atherosclerosis ensues. And therefore, some of the stress tests could be positive up to the extent of 25% in these hypothyroid cases, but nevertheless the coronary artery disease may not be established on the angiogram. But should there be established disease, then of course the treatment plan should be based on, as we just discussed here. In suspect cases, always start with 25 to 50, but if you have stable angina, start with 12.5 of l-thyroxine, obviously. And in unstable anginas, patients who are definitely going for, say, left main disease or triple vessel bypasses or PCIs, do not start until, because these are established cases, you don't want to increase their heart rate or their hemodynamics or the utilization of the oxygen rather abruptly until and unless after post-operative phase has set in. That means they have been successfully bypassed. So in a nutshell, you've learned something about hypothyroidism and its on cardiovascular and its effects on cardiovascular system. So stay tuned for more video vignettes as coming now. We are getting into more exciting stuff now. And thank you for watching MuniMeterHealth.com. And so long until the next video.